How do you recognize its liver? Obviously, portal tracts, central veins, everything recognizable here. These mostly are portal tracts or triads with what you should mention here would be the biliary duct, should be the central vein here and the arterioles, and, well, the vein vessel, it's not a central one. And there, it's a central vein. What do you see here? First, stasis of bile or cholestasis. Some perinuclearly positioned also lipofuscin pigments, which are normal. Some bubbles inside in the hepatocytes, which suggest to me that there might be liver steatosis. And finally, what we observe in the portal tract is that the border laminae is damaged and there is inflammatory infiltrate, which is pretty much predominant here. But we could not call this event hepatitis because we should see definite changes also in the surrounding structures. In the hepatitis, we should see necrosis, different types. We should also it should also perform with fibrosis. Inflammatory infiltrate should be not this concentrated in the sinusoid cells like we see it here. And in this type of change, if we take a look closer at the cells of the inflammatory infiltrate, we see that they are enlarged, much larger than the surrounding erythrocytes. These are not appearing either as mature lymphocytes or mature plasmocytes. These are actually blast cells, which are positioned in the portal tract of the liver. Suggesting this one, we may see that perhaps this is a sign, actually for sure, this is a sign of extramedullary hematopoiesis, which happens in the portal tract when there is a process of leukemia going on in the organism. So what we observe here is a sign of leukemia. Later, by checking out and some other signs, clinical, majorly in hematological, the determination would be chronic myelogenous leukemia. But what you see from here is the evidence of increased portal tracts, disturbed border lamina. Sometimes we may see hyperproliferation of bile ducts, which is not something not quite expected from this type of liver. And take a look at inflammatory infiltrates also. They could be in clusters in between the hepatocytes in certain places. This also may appear normal. Of course, bile stasis and evidence of these immature cells which are crawling also in the sinusoids. This is all appearance of extramedullary hematopoiesis in this type of process, and it appears to disappear again. Yeah, I'm finished with this one. It's connected to extramedullary hematopoiesis. In embryonic development, I should explain this one. In embryonic development, there is production of blood cells, not only from the bone marrow and specific types of bone marrow and specific bones and organs, of course, which are involved in the production of the lymphocytes and leukocytes. It was also produced by the spleen, by the liver, in kidneys sometimes. Even in brain, there are structures which could produce primarily immune cells. Later, all of this production is depleted, it disappears after the birth of the child because it's not needed anymore. And as far as you can see, the same is about the involution of the thymus, which stops producing immune cells at the age of puberty and it's replaced by fat tissue. Same happens here. But when there is immature population of cells which is circulating, the organism gets the information that there are more cells of the immune system needed. So it pushes embryonic development and embryonic production to happen again. This is the case of extramedullary hematopoiesis, when there is production, for example, of different lymphatic cells from the bone marrow of the long bones. The femur produces very often, and it's increased in structure, also in volume, which pushes the bone structures aside and causes atrophy. That is why these people very often suffer fractures. Also, there is increased amount of immature blood cells in the portal tracts and in sinusoids, increased amount of blood cells in the kidneys sometimes, in the spleen very often, because as long as the liver produces more cells and it's increased, the spleen needs to destroy these cells, so it's also increased. That is why in this type of leukemia, for example, we often see hepatosplenomegaly. And that's the case for production of these cells. So may we now continue with the next one? This one is clear. Leukemia as identification is not our job. It's actually performed by hematologists, which can see which type of cells are more pronounced. There is also flow cytometry performed by the immunologists, and they decide which type of leukemia they observe. What we can do here is identify eventually which type of blast cells we observe by immunohistochemistry. But in this case, we do not have it performed, so we cannot decide actually. So we cannot be sure about this type of diagnosis. What we see is clusters of immature blast cells produced here, which could lead us to the conclusion that there is process of leukemia. But I myself cannot give the diagnosis and be sure without cooperation with the other clinics. This is not the case of lymphoma. Lymphomas are pathologists' job. We can identify which type of lymphoma we observe by panels of immunohistochemistry. And we can argue with each other sometimes depending on the type of immunohistochemistry, which is more positive or less positive, and in which structures it's positive. But in leukemias, the case is not so easy. Is that clear? Okay, so we should continue now with the next one. Liver.